Okay, thank you for recording it, Elizabeth. We are recording these sessions and we will have a link to them for viewing after the session. So if you can't make it to one, we will have them available for offline. All right, is everybody able to see that?
Yes.
Okay. Okay, great. Okay, so like I said, we are in the Project Echo Pregnant and Parenting Women with SUD project. Very excited to collaborate with Marshall and WVU Medicine. My name is Jay Mason. I'm the director of the ECHO program at the West Virginia Clinical and Translational Science Institute. Heck of a mouthful, so we'll just say CTSI for short. And so we've been doing these echoes now for almost 7 years. So we're very glad we could partner with Marshall. They bring a lot of experience, and as well as with the group from WVU. So we're hoping it can be really a robust project for everybody. Learn a lot. So the ECHO model, what makes it, what is ECHO? Why does it make a difference than any other, Zoom meeting you've done since the pandemic, right? So ECHO stands for Extensions for Community Healthcare Outcomes. And really what this is a mentoring and training type of model for primary care docs, nurses, anybody that touches care in primary care. And we tend to think about it like telemedicine. Instead of that point-to-point care for telemedicine, ECHO is a group of experts on one end that we call the hub in an area such as SUD. And then the spokes are your primary care providers, nurses, and teams that are looking to gain more knowledge and mentoring around this topic. So that's really what ECHO kind of separates itself. But it's easiest to think of like telemedicine because you are on video and those kinds of things. There's core principles. We'll just go over these real quick, but use technology. We're using Zoom. Everybody has used Zoom now. We share best practices, and this is a huge thing. This is really what we're talking about with the cases as well, the case-based learning, is that we really want to get the best practices from everybody, not just the hub team, the expert team, but everybody. Everybody's dealing with certain situations or some of the same situations. We want to hear your experiences, what you've done. That's what's most important. We don't want to be up here talking at you the whole hour. We want to have that back and forth with the whole group. And then web-based, this gets back to the data monitoring outcomes. It's not just only outcomes, but it's also attendance, who's presenting cases, the didactic portions of it. It's really just keeping tracking, making sure that we're keeping up with who's doing what. So nothing to, when you see monitor outcomes, we can get to that, but the essentials are the basics there that I talked about. And then the goal of ECHO is really about, for patients, it's the right care at the right place at the right time, right? West Virginia is a hard state to get around in, not a lot of specialists, so keeping them in primary care longer is beneficial. Hopefully that helps with the referral process and wait times and things like that. For the provider, it's treating more patients, gaining knowledge, hopefully building a community of practice, with this group here on the call. Hopefully everybody can get to know each other a little bit and, lean on each other, not feel like you're on an island by yourself while you're treating these patients. And then for the community, hopefully it will reduce disparities, retain providers. That's a huge thing in West Virginia, retaining your providers. Hopefully they can feel connected and they have a community to rely on, and then to keep patients local. And then with the ultimate system level goal is increasing access, increasing the quality, reducing costs, all those great things that we always talk about when we are trying to improve healthcare. So you probably saw these on the slide, the pre-session slides, but just some tips and tricks with ECHO. We want to be mindful of time if you're presenting or providing advice or expertise. We ask that you turn on your video if you can. We understand people are in the clinical setting and sometimes that's difficult to do. If you're eating lunch, your call. We don't care if you're eating lunch on camera, but that's up to you. There is the raise hand function feature if you open up your participant or chat box on Zoom. So you can always raise your hand and we can look for those and call on you. But again, this is pretty informal. We keep them pretty informal. If you have a question, unmute and interrupt and we'll do our best to answer your question, or you can just simply put it in the chat. No PHI. So case presentations do not have any PHI. We don't talk about specific, in specifics around certain patients and things like that. So that's really the biggest rule that we have. It's just no PHI at any time. We are recording it, so if we do happen to have a PHI slip, we will go back in the recording and cut that part completely out, and it's no longer a part of the recording, just so you know. Obviously, we talked about direct messaging. If you guys have any technical issues or anything like that, please feel free to message myself or Elizabeth or Mitra from the Echo team. They'll be happy to work through any troubles you might have. And then this is a funny one, but silence is good. Just because we ask a question and nobody answers right away, that's all right. Everybody's thinking, everybody's trying to get their mind right. Silence is okay. So if you see me waiting a little bit, it's not because I've frozen. It's because we're actually waiting to see if somebody's going to respond. Remember to unmute and mute. That's pretty standard operating procedure now with Zoom. And obviously, we want to treat everybody with respect. This is a safe place. So ask all questions, any questions. And then most importantly, let's hopefully have some fun. Hopefully you feel connected through these sessions. This gives you, you probably have seen this from the recruitment emails and the Zoom registration, but this shows you the curriculum for the upcoming sessions, and you will always get a reminder about the next session and things like that. But this is just to give you a little bit of a preview. And really, we want to have a discussion. We really want to have a collaborative discussion with everybody around these topics, around these cases, to hopefully everybody feels included and they're gaining the knowledge they want to gain. And then if there are any additional topics, you see a couple of TBDs there at the end on the schedule, or anything that comes up, please do not be shy and put it in the chat. Email us after the sessions. We want to make sure we present information that is important to you guys and is what you need. So please let us know if there's other topics you want us to try to address. We're happy to try to fit those in and rearrange the schedule as best we can. Real quick, I wanted to follow up on the Zoom registration questions. So one was about continuing education credits. They are available. They will be done through the Marshall office. Lynn O'Connell, who I believe is on, I don't see her in my small Hollywood squares, but I believe she is on. We will be sending the attendance to her to fill out the appropriate CE information that's needed. If there's anything we need to follow up with anybody on, we'll do that through email, through a personal, one-to-one email. But it is offered. Now, it is available, I believe, to most, right, Lynn? Am I correct? It's MDs, doctors. Is it available for nurses? I couldn't remember from our last discussion.
We're working on the MD ones, but there's a chance that we'll have nursing available as well. And for other, they should be able to submit to their board their attendance, having completed the evaluation, and then we can certify that later. Great.
Yeah, so at any point you have any questions about CE, please let us know. We know it can be tricky and there's different things for everybody, so just let us know. And then also, this is a little bit different from some of the Zoom and some of the echoes we've done, but you need to use the link that was in your confirmation email from Zoom, from WVCTSI Project Echo Zoom, to join the sessions. There also is instructions on how to add that into your calendar through that confirmation email. We are unable to send you a calendar invite because it has to be specific to you as a registrant. It's a little quirk with Zoom. We'd hope they really make that automatic at this point. But so if you have any issues or you don't see it on your calendar, let us know. We can try to work that out with you. But that was also a question from the Zoom registration about how to access the future sessions. Again, here's the team. We'll send you out a recap email with these links to our website and how to view the sessions on YouTube afterwards. But like I said, feel free to email any of us if you have any questions. We're here to help make this an enjoyable experience, and hopefully they get a lot out of it. Does anybody have any questions at this point? Let me stop share. I see people are putting in their name and everything for registration. Appreciate that. Any questions before we move forward? I know I speed read through that, but okay. Oh, I see Dr. Hanson, you unmuted. Are you okay?
Yeah, I'm good.
Any questions? Okay, I will, let me share your slides. We'll turn it over to Dr. Hanson. He will be doing the didactic portion of today's session. Again, chat in any questions you have, or wait till the presentation is over and we'll have the open discussion. All right.
All right, well, I guess it's good afternoon to everyone at this point. Thanks for having me to sort of talk. I'll make a couple sort of disclaimers going into it. I have took this from another talk, and so if you've heard some portions of this talk before, I apologize, but it's good basic information, so I wanted to sort of share it again, and I think it's the basics of what we need to know, sort of starting this off. So most of these slides are coming from the PCSS MAT qualifying course slides, and so this is a 4-hour course that medical providers and nurse practitioners will take in order to get the certificate for prescribing with buprenorphine products. And so I always want to give them credit of where I got the slides from primarily. All right, if we can go to the next one, please. So this is sort of the website. They have a lot of resources, obviously a lot of connections with a lot of different organizations related to things to look up and just sort of support. And you can actually sign up for mentors through their site as well. So wanted to include that information as well. All right, next slide. All right, so primarily going to be talking about 3 different medications today. The first being methadone, buprenorphine, and then naltrexone. We'll have some sort of graphics to sort of show the difference, but just want to make note that, that methadone is a full agonist at the opiate receptor, and we'll talk more about that. Buprenorphine is a partial agonist, and then the naltrexone is an antagonist. And so we'll do a little physiology, pharmacology, talking through that. You see the typical doses for all 3 medications and some of the advantages of utilizing that medication. I will sort of make note, methadone obviously in West Virginia is only done out of a treatment center. That's our laws, that's our legislation. Buprenorphine can be done in a primary care office, so outside of a typical methadone clinic, and then naltrexone can be done essentially by anybody in any office setting, whether they're certified or not certified necessarily. So next slide, please. All right, so we'll start off talking about buprenorphine. So we'll try to just use the term buprenorphine, but this also includes Subutex or Suboxone, Sublocade. It's a semi-synthetic analog of thebaine. If you're breaking back to organic chemistry, was first approved in 2002 as a Schedule III medication for the treatment of opioid use disorder. Data 2000 was sort of landmark legislation that allowed treatment of opioid use disorder to move from the sort of typical methadone treatment clinic and into the primary care office. And so Suboxone was sort of the first, or buprenorphine was the first medication to utilize that change in regulations. Metabolized mainly by the liver into a less active metabolite, which is norbuprenorphine. This is most pertinent, honestly, for drug screens. You should pick up more norbuprenorphine in a urine drug screen than buprenorphine. And so if you have someone that's consistently with buprenorphine and very little norbuprenorphine, then they're probably taking it right before the drug screen. And so you can sort of catch them on their compliance. And so that's always a little pearl that is helpful. Usually primarily excreted in the biliary tract, but there is a small amount in the urine. Has extensive first pass metabolism. So what this means is if you swallow it and it's absorbed into your system through the gut, you're not going to get very much of the medicine, less than 5%. And so because of this, you typically put it under the tongue or against the cheek, depending on the formulation, and you get more of the medicine gets into your system. And so if you have patients that are swallowing their medicine, they're typically going to report that symptoms are not very well controlled, and they're going to be requesting more and more medicine because they're not getting much that they're taking. And so you can sort of see sublingual administration bypasses the metabolism, has bioavailability of about 30%. So a 6-fold increase swallowing versus putting it under the tongue. Next slide, please. All right, so why do we like buprenorphine so much? It has a couple characteristics that really make it good at its job. And I always try to tell patients the job of buprenorphine is to keep you from being sick, because of withdrawal symptoms is one of the primary reasons that patients return to use. They can't stand to be sick when they know they can take something and feel better. And so the affinity is the strength at which the drug binds to the receptor, and we're typically talking about the mu-opioid receptor at this point. And so because it has such a strong affinity at that receptor, it will displace other medications or other opiates like heroin or methadone. And so this is important for two reasons, one of which is if you have buprenorphine on that receptor and someone were to have a relapse and use heroin, that heroin molecule isn't going to be able to attach to that receptor. And so it has sort of a protective or blocking effect, so that with a relapse, they're unlikely to get the same sort of effect from the heroin that they may if the Suboxone or buprenorphine wasn't there. It also has dissociation, which is very slow, which means once it attaches to that receptor, it's going to stay on that receptor for a long period of time, which means that you don't have to take it multiple times a day. It's going to attach, stay, and be there. We typically are dosing once or twice a day. All right, next slide, please. All right, so sort of looking at the slide here, you can see the three different medications we're going to talk about. But if you pay particular attention to the blue line or the buprenorphine, you'll see that as the dose increases, you initially are going to get more and more effect, but you're going to reach a dose in which you have very little effect, even as you take more and more. This makes it particularly helpful because you don't have that feedback of more is always better. More is just a waste of money at this point to take more. It also makes it a lot safer than other medications like methadone and morphine, because the more you take isn't necessarily going to push you into overdose. An overdose situation with buprenorphine is relatively rare if it's the only medication that's used, but the primary time that you would need to worry would be buprenorphine in an infant or a young child, in which the dose can have significant effects. So long half-life, this is the time that it takes to get half of the medicine out of the system, 24 to 36 hours. Again, high affinity at the receptor, so it blocks other opiates. It can displace other opiates, meaning if you have heroin or fentanyl sort of on board at the time, and then you take a Suboxone, it's going to pull those medications off and precipitate a withdrawal. And so that's an important education feature as you're sort of inducing or starting someone on buprenorphine. And then, as we mentioned, slow dissociation from the receptor, so it stays there for a long time. So sort of going back to the top of the slide, that minimal respiratory suppression and no respiratory arrest when used as prescribed. I had some slides sort of showing that oxygen saturation doesn't decrease, number of respirations per minute doesn't really decrease, even at the higher doses of buprenorphine. Next slide, please. So what are some of the adverse effects of buprenorphine? Patients will often sort of complain about these. The number one is headaches. Always tell patients that this is a side effect that tends to be dose dependent. And so the best way to get rid of it is to move to a lower dose. Patients don't typically take me up on that offer, but it does respond fairly well to ibuprofen and Tylenol. Nausea, which is a class effect with most opiates. So you can consider spitting out the saliva after adequate absorption. Constipation, again, opiate side effect. Stay well hydrated, high fiber diet, stool softener, laxatives as needed, dry mouth. Don't notice this a lot, but I do have a lot of patients who report dental related issues to their Suboxone. They blame the Suboxone. I'm a little bit wondering if it's just sort of poor dental practice during their active addiction, but we do have this a lot, and there's probably not a week that goes by that we don't have a couple of patients that come in with dental issues and wanting antibiotics for infection. If you have access to a dentist, it would make your life a lot easier. So stay well hydrated, good oral hygiene to sort of go against or to treat sort of that side effect. Next slide, please. So sort of talking about buprenorphine, you have sort of two different primary products. You have monobuprenorphine, which is Subutex, and then you have the combination buprenorphine with naloxone, which is your typical Suboxone. And so the reason that the naloxone was added was to try to decrease the IV use of buprenorphine. And so if the naloxone is injected, the naloxone is going to be active and can precipitate a withdrawal, versus if it's placed under the tongue, then it's at a much lower dose and it's not going to be active and can safely be taken. And so this was sort of a protective feature that was added to buprenorphine to try to prevent IV use. I will tell you anecdotally, I'm not completely confident that it works. I've had patients that have reported IV use of Suboxone. They have an initial sort of mild withdrawal syndrome, and then they get sort of the desired effect of the higher dose of buprenorphine with the quicker onset, once it wears off. But standard practice still is to use the combination product from a safety standpoint. Next slide, please. So kind of like a busy slide here, but just wanted to put in here sort of the different combinations and different formulations for buprenorphine, along with their doses. So you can sort of see Suboxone branded, and then also Suboxone naloxone sort of generic with the different formulations. There's a sublingual competitor to Suboxone called Zubsolv, which also goes under the tongue. A little bit different dosing there. They have a buccal film, so instead of under the tongue, you're putting on the inside of the cheek, called Bunavail. The mono product is called Subutex. There's an implant, which is for up to 6 months. It's put in the inner arm. I have not used this myself. I have not seen it done. There has some concerns about that sort of efficacy and long-term use of taking them in and out every 6 months. But in theory, was a product that was brought to market. And then there's an injection called Sublocade, which is monobuprenorphine, and it's once a month injection. It's been out for a couple of years, but it's fairly pricey and just recently has sort of been picked up and covered by Medicaid. There's another product that is not out yet that is working through the FDA, and it's called Brixadi, and it's a sub-Q injection that's either weekly or monthly. So there'll be a little bit of competition for Sublocade, potentially at some point once it goes through their legal sort of channels and gets a final approval. It is used in Europe at this point. Next slide, please. All right, so we'll sort of move on to the second medication, which is Naltrexone. So Naltrexone is a long-acting, high-affinity, competitive opioid receptor antagonist. And so what that means, it attaches to the mu opioid receptor very tightly, but it's an antagonist. So what that means is it attaches to the receptor and doesn't really have any effect, versus buprenorphine that attaches to the opioid receptor and has some effect. So it opens ion channels and sort of releases other chemicals. And so it attaches and does nothing essentially. And so insufficient plasma concentrations, it fully blocks all opiate effects. And so if the naltrexone is attached to that receptor and you have any other opiate, it's not going to be able to get to that receptor and it's not going to have any effect. There are two formulations. There's a tablet, which is approved for treatment of opioid use disorder, also associated with alcohol use disorder. It has a relatively poor daily adherence. You have to take it every day. If you don't take it for a day, then theoretically you can return to use. Naltrexone is a monthly injection, so you only have to make the decision to maintain sobriety theoretically every 28 days, and so compliance is much better. And so it's an appealing choice for patients who prefer not to be on any opioids. There's a lot of different sort of philosophies, but some people feel that buprenorphine products are just replacing one drug for another. Obviously, adamantly disagree with that. But for some individuals, naltrexone is a good option, and I've seen patients do really, really well on it. And then you can see the little graph and sort of looking at the concentrations, you sort of see, with the shot that you get sort of a high amount, and then it just sort of fades over time versus the up and down of the oral naltrexone daily. Next slide, please. So sort of looking at the features of naltrexone. So looking at the red line here. And so obviously, even as the dose gets higher, there really isn't any effect. And so there is no withdrawal. There really isn't any effect from it. Once you've had the shot, whether it was a placebo or naltrexone, you theoretically shouldn't feel too much of a difference from a physiological standpoint. So oral lasts about 4 hours, half-life, intramuscular 5 to 10 days, very high affinity of mu opioid receptors, so it blocks all other opioids. It can displace other opioids, and so this is one of the issues with the initiation of naltrexone, which we'll talk a little bit more, I believe, in a slide or two. And then the formulations is Revia, which is the oral, and then Vivitrol, which is the intramuscular injection. Next slide, please. So 2 possible mechanisms for the therapeutic effect of naltrexone. So you sort of have the behavioral mechanism. And so by blocking the reinforcing effects of heroin, sort of leads to gradual extension of the drug seeking and craving behavior. And so because they can't get any positive reinforcement or positive effect from the opioids and they stop using it, often tell patients, if you use an opioid and you puked your guts out and you didn't like the feeling at all, then you probably wouldn't use it a second time. But those individuals that use an opioid and it gives them energy, or it makes all their problems go away, or it makes them happier than they've ever been, or tend to use it a second and third and fourth time, and you sort of build a habit from that standpoint. There's also the pharmacological mechanism. Naltrexone decreases the reactivity to drug conditioned cues and decreases cravings, thereby minimizing pathological response, contributing to relapse. There's evidence, both adults and also animal studies, that naltrexone tends to block sort of the reinforcing effects of a lot of different things, whether it be sugar or from gambling, or, fill in sort of your potential addiction in some capacity. There is also some evidence of naltrexone helping with methamphetamine dependence, although it is not FDA approved, and the studies are still not very robust at this time. Because it has a different mechanism, the methadone or buprenorphine, it may be acceptable or more effective in different subgroups of patients. That's helping to attract more patients into effective treatment overall. We find that majority of naltrexone is most likely used related to post detox in an inpatient or residential setting, or post judicial, when someone has a forced detox in the judicial system and they're ready for discharge or release. Giving them naltrexone gives them sort of a 30-day window to get into treatment and sort of support them in maintaining their sobriety. If there was a relapse, they would be less likely to have any effect, from that relapse, which hopefully will sort of break that habit of continued use. Next slide, please. So sort of considerations for initiation. Official prescribing information recommends that patients are opioid free for 7 to 10 days before treatment can be initiated to avoid a precipitated withdrawal. So if there are any opioids on that mu opioid receptor in the brain, and it's going to pull those receptors off, it's going to precipitate a withdrawal, and the patient is not going to be very happy with you. And so they have to be opioid free. This is one of the barriers, because, I always say, if patients can maintain sobriety for 7 to 10 days, and they're typically not showing up into our clinic and asking for help. At that point, they probably feel like they've got it kicked. They don't need formal help, and we'll just sort of go. For this is the reason that it seems to be used out of the judicial system, or sort of a detox situation in which they get support and being away from the temptation. There are some other more rapid methods for naltrexone initiation that they're sort of working on, but there aren't any, to my knowledge, sort of formal best practice, that is with widespread use. Next slide, please. So adherence, treatment adherence can be challenging, but it's better with the long-acting injection. Again, oral versus injection, making the decision every 28 days versus daily. Oral naltrexone is not really recommended for treatment of use disorder because of this. Some patients may experience some withdrawal after the first injection. Typically will get better within the first couple of weeks, and typically is not present with the second injection. Treatment should include ongoing counseling, anticipatory guidance, motivational interviewing techniques, mainly emphasizing adherence to the program. Involvement of a significant other may be helpful in adherence. Always good to have someone at home sort of pushing them in the right direction. There can be some soreness at the injection site. Sometimes patients will report a knot. Just sort of need to keep an eye on that and make sure that it doesn't turn into infection, which is highly unlikely, but is possible anytime that you're breaking the skin. And then the main safety concern is risk of relapse when injections are discontinued. And so patients that disappear and don't come back for their second or third or fourth injection, the concern is they have now been sober for 28, 56, 84 days or what, and their tolerance is much, much lower. And so if they return to use and go use the same amount that they did prior, and their tolerance is much lower, then they're at risk for overdose. There was a study that was done that sort of followed this. It's one of those things that in theory you would assume that they are higher risk for overdose, but their risk of overdose doesn't appear to be that much higher than the general population. But it's still very much a concern and something needs to be discussed whenever you're initiating naltrexone treatment. Next slide, please. All right, so talking a little bit about methadone. So methadone is full agonist at the mu opioid receptor, which means that the more you give, the more chemicals are going to be released. And as you can see from the green line, it just keeps going up and up. So the more you give them, the more effective that it's going to be, and it doesn't really plateau. And so when you give enough, eventually, they're going to stop the respirations and you're going to put them into an overdose situation. It's long half-life, 15 to 60 hours. This is one of the things that makes methadone fairly complicated because you have one individual with a half-life of 60 and one that may have 15. So the one with 15 probably would do well with dosing every day. Someone with a half-life of 60 really only needs to be dosed every 4 or 5 days. And so to determine which camp the person falls into can be a little bit difficult, and you have to be very careful with dosing. It has a relatively weak affinity at the mu receptor, meaning it's easy to pull off with buprenorphine or other substances. It has to be very closely monitored. You can have significant respiratory depression, respiratory arrest with overdose. It can cause some QT prolongation. This has to do with the electrical activity of the heart, and it can cause some abnormal heart rhythms, which can be very dangerous. Next slide. So sort of moving into our special population here. So factors to consider in the pregnant patient. If the patient elects to start or stay on buprenorphine, that's fine. Document informed consent. You need to let the mom know of the risk of NAS if they're going to be treated with buprenorphine during pregnancy. You need to obtain consent for release and information from the OBGYN if you're not the OBGYN taking care of the patient, so that you can do integrated care. Consider starting with or switching to equivalent dose of buprenorphine monoproduct. These slides are a couple years old at this point. In West Virginia and many other states, Suboxone is on formulary for pregnancy, and there is not a reason necessarily to switch to the monoproduct. There was initial concern that maybe the naloxone component was going to pass through the placenta and affect the infant, but at this point, that does not appear to be true. If a patient is on an outpatient treatment program with methadone, they typically will do 30 milligrams on day 1 and then sort of increase over time. Next slide. All right, so this is just sort of what we've already talked about. So buprenorphine with or without naloxone in the pregnant patient. There's no known teratogenic effect in animals. There have been some controlled studies at this point and it's shown to be safe. So buprenorphine without naloxone is still sort of recommended in the pregnant breastfeeding sort of population. Next slide, please. So pregnancy and methadone treatment. Formerly, methadone was considered first line. At this point, buprenorphine is considered first line if it's available. You need to titrate to effective dose to reduce cravings. Typically in the second and third trimester, you're going to need to increase the dose of methadone, secondary to increase metabolism and increase circulatory blood volume. Doses may need to be split for this reason. And then with advanced gestational age, plasma levels progressively decrease, clearance increases, thus sort of the increased dose or moving to every 12-hour dosing, which is difficult to do when someone is going to the methadone clinic and dosing once a day. Next slide. Looking at infant outcomes, there's definitely a difference between methadone and buprenorphine. You can see the total dose of morphine for treatment of NAS with methadone versus buprenorphine. Obviously, buprenorphine is far superior as far as mean hospital stay and length of stay, and the mean duration of NAS treatment. Again, significant difference between buprenorphine and methadone. This study was sort of groundbreaking in that it pretty much without question showed that buprenorphine is the superior product to be utilizing during pregnancy. I used to tell patients, back when I first started that, at the time methadone was the gold standard, but at this point, I've luckily been doing this long enough to see that change, and a majority of moms are now getting put on buprenorphine, which is significantly better for the infants. Next slide, please. All right, just to sort of throw out there, we're talking a lot about medication, but I cannot stress enough the importance of a well-rounded, holistic program. And so I wanted to create a slide sort of stressing this. So you need to have consistent urine drug testing, both screening and confirmatory. I don't want to get on my soapbox, but the instant cups are not very good. You need to confirm it and get accurate results. You need to be doing individual and group therapy. I know that's hard during COVID, but medication alone does accomplish some, but in the long term, to improve quality of life, I could not agree more with the fact that individuals need to be involved in therapy. Peer mentors and recovery coaches, which is sort of a growing area within the recovery community, but I think can be very helpful as you create a team approach to treatment, case management, and family navigators. Access to consistent pharmacy. We are fortunate in Huntington and some of the larger cities to have pharmacies that are willing to fill prescriptions, but there are still areas in rural West Virginia where patients have to drive a considerable amount of time in order to find a pharmacy that's willing to fill their prescription. Weekly medication visits typically is the norm, but if patients are doing well and are maintaining sobriety and doing well in the program, should have the potential to phase up, so they're not having to come every week. And then you need to have a discussion of how to handle other substances of abuse. And this is a topic that is a lot longer and more complicated than we have time to discuss here. But you need to have that question of how you define success and what are you going to do with the individuals who may be opioid free but may be testing positive for other substances, whether that be THC, cocaine, methamphetamine, alcohol. Fill in the blank with the other substance. So it's a very complicated and difficult question, but something you need to consider. And at the end of the day, it comes down to, how are you defining success in your treatment program? Next slide. All right. And I don't know if I went long or short or what, but I felt like that was pretty good. So thank you. And, we'll stay on and answer some questions, if we have any.
Thank you, Dr. Hanson. No, you did great. Thank you so much. We'll open it up for questions here before moving to the case. Does anybody have any questions? Feel free to unmute and blurt them out. No questions. He covered everything. We're good to go. We can just move on, right? Yeah. Oh, here we go. Does anybody have any follow-ups? Dr. Hanson, I'll follow up with one question. I'm not a provider or anything like that, but you talked about the program and having it's not just the medication and things like that.
Yeah.
Is it a hard sell when you have a patient and you tell it's not just the medication? When you talk to them about other things that need to go into it?
Generally no. I don't feel like it is. What if they're coming here and they're asking for help? I think majority of them realize that medication alone is really only going to get them so far. Their life a lot of time is turmoil, with failed relationships, legal issues, significant health issues, et cetera, and so, looking for a quick fix with a medication was honestly probably what got them there in the first place. And so very rarely do we have an individual or a patient who is not open and willing to do the therapy component. Some like it more than others, but relatively rare is the individual that doesn't want to or isn't willing.
Okay, thank you. See, it's not too bad. It's not too hard. Any questions? One last call for questions, or we will then, if not, we'll switch. We'll switch over to Laura. All right, if anything comes across your mind, please put it in the chat while we're transitioning over. But Laura, give me 1 second. I will share your case. And again, just to remind everybody, this is an example case that we're going to go through, hopefully have a discussion, but also keep in mind, this is kind of the format of the case presentations. We do have an electronic form for it that you don't, it's not a PDF or a Word document you have to fill in. It's an electronic form. We did have some technical issues that we're trying to iron out before we send it to you to fill out. But it is, you can copy and paste from your EMR if you so choose, or from any notes you might have. And then it's sent to us, and it's in a secure database that we will then make a PDF to share on the screen that you're about to see. But just wanted to be clear on that. And Laura will kind of get into that a little bit as well, just a little bit, but wanted to make sure everybody was on the same page. So Laura, here
Yes,
we go.
as Jay mentioned earlier, the cases really make the didactics come alive. So the cases are actually my favorite part of ECHO, because it really allows us to kind of apply what's been talked about in the didactic to a real situation. So I'm Laura Lander from the Department of Behavioral Medicine and Psychiatry at WVU in Morgantown, and I am part of a team that facilitates treatment to pregnant and postpartum women with substance use disorders. So this is a case. This case is from that clinic. It's an individual that a couple of the members of the hub team have worked with. And I've changed some of the demographic information just to make it not so identifiable, but not any of the information that's really clinically relevant. So this is a 31-year-old female patient who actually entered into treatment in April of 2020. So we've been working with her for a while. And as some of you may have experienced, she came into treatment not during her pregnancy, but immediately after the removal of her infant. And we see that, and often this is the case that women who are pregnant don't seek treatment, I think, in a large part because they are afraid of the stigma that they might experience should they seek treatment and have a known substance use disorder, or they're afraid of the removal of their children, who, if they have other children in addition to the pregnancy, if they were actually to come into OB care or seek treatment while they were still pregnant. However, what we know is actually her worst fears were then realized when she came into treatment afterwards, because her children were all removed from her care anyway. So she came into residential care with us initially and was diagnosed with opioid use disorder, stimulant use disorder, postpartum depression, and generalized anxiety disorder. And she did have a history of IV use, and she did have hepatitis C, for which she had not received any treatment. So the patient grew up in Indiana, graduated from high school, moved to West Virginia to be near her father after the death of her mother when she was 18. One biological brother who she is not close to, so that's not a support for her. And her father did die of substance use related issues about 8 years ago. So she has, so this is like, currently the children are these ages, and the youngest three have the same father, the oldest has a different father, and the father does also struggle with substance use disorder. Initially in treatment, they were together, and after about a year, it became very clear that she was not going to be able to be successful in her recovery if she stayed with her partner, and so they have separated. She did relapse on methamphetamines in August, And this was after her children were returned to her briefly, and then they were removed again, and she relapsed after the second removal. And the removal was related to her partner's relapse. So fast forward to today, she's had, I'm gonna go up to the lab results. She's actually had urine drug screening throughout the 18 months that CPS has been involved with her. And in August, following her relapse, they started to do blood screening. And so anyone who has any expertise in blood screening, I need some help. So she's had, I don't know, she's had at least 7 screenings. We haven't received all of them, but I have looked at the results of some of them. And off and on, more on than off. So about, maybe she's had 8. So about 5 or 6 out of the 8 screens, she's had these very low positive levels for methamphetamine. The cutoff is 5 and the levels are 6.5, numbers like that, or the cutoff is 5 and the levels are 10, very, very low. And she adamantly denies any use of methamphetamines, and her behavior is really not consistent with methamphetamine use. We increased her treatment following her relapse to what we called a modified IOP, where she attends treatment with us 3 times a week. She also has visits with her children twice a week, and she has screens with CPS usually once or twice a week, and she has a full-time job. So this is an individual who's actually been making all of these appointments, which for any of you guys who work with folks in active use with methamphetamines, they typically are not able to achieve this level of compliance with treatment and all the other appointments. So I actually believe from a clinical perspective, what I see clinically, that she's not using methamphetamines, but CPS, based on these very low levels of methamphetamine in her blood, none of the urine drug screens have had methamphetamines. I believe they're likely to terminate the rights to all 4 of her children. And so my question for the group is really about, does anyone have any thoughts about these low levels of methamphetamine in the blood only and not in the UDS? And also, you know, for those of you who work with people who are involved with CPS, there's sometimes a point in our treatment where we have to help people prepare for termination as opposed to reunification. And that is a very difficult transition for the patient, obviously. And actually for me as a provider too, like it breaks my heart but I feel as if we're sort of there. She has a court date coming up in January, and then she'll probably have a final court date in February where that will be the decision. It's either termination or unification, because it's been almost 2 years that they've been removed. So that's kind of the case that I wanted to present, and I'm open to feedback, suggestions, and sharing of other people's experiences.
Thank you, Laura. Yeah, so typically this is the time where we'll ask for any clarifying questions. If anybody has anything they want to ask Laura to clarify on the case that you're seeing shared. And then if there aren't really any of those clarifying questions, then we'll stop share and go into more of the discussion of the questions that Laura asked. So first, let me ask if there are any clarifying questions from the group on the case.
This is Janine Brow. Oh, sorry. I had a quick question.
Sure.
You mentioned that she had requested counseling for her children who were fighting, and they had not received that. I was just wondering if you could elaborate on why that has not been accessed.
So it's unclear to me. She was eventually referred to a program where that was provided. So to date, and it's January 2022, there have been 2 therapy sessions. The kids have been in care for over 18 months. And so I don't know the answer to that. CPS was not great about returning my phone calls when I've reached out in an effort to advocate. I have been in touch with the program who's providing the therapy, so they were responsive. in my mind, this therapy should have happened prior to the children initially being returned to her. Now they didn't stay, they were then again removed, but there was no therapy in advance of that initial reunification, which was highly problematic when you got these 4 kids back in the house with a mom who then became very overwhelmed.
Yeah, thanks for that. So do you feel, I guess, so it's sort of, I'm not to say it's a failure of the CPS system, I'm not trying to cast blame, but where did things fall apart? And when we're trying to treat a family, so it is sort of, that was requested of the CPS system by the mother.
Yeah, I mean, I've worked with moms who this has worked much better. The therapy, I mean, I'm working with a mom right now where the therapy is, she's getting therapy with her kids and they were removed 4 months ago. Like the therapy's already started, which is great. And she hasn't even started like official visits, but they've started therapy together. So this is not my experience of how it always goes, but this is how it went in this particular case.
Okay, thank you.
Laura, I was wanting to ask whether you knew the contractor that CPS is utilizing for their drug screens. Here in the southern part of the state, I've never heard of anyone doing blood tests who's working for CPS. We usually go through Day Report Center down here, and that's all urines.
Yeah, it's Day Report that's doing them. I mean, it's not Quest. It's the lawyer was in touch with the lab to try and get some information on how to interpret these results. And it's like South Carolina, or the lab is somewhere else. But the urines are, I mean, the blood is done through Day Report, and then they contract with the lab. And the individual she talked to at the lab said, this is the only way that they could interpret it was that she has some low level of exposure, not necessarily direct ingestion, but she lives alone. She's not around, by her report, she's not around anyone who's using. She stopped vaping because she was afraid that it was vaping. And they, at this point, they're asking her to move out of her apartment. She was homeless, into a shelter to make sure it's nothing in her apartment. And I gotta tell you, I am not supporting that recommendation because, in the shelters in the Morgantown area, I know she will be offered substances and she will be at very high risk to relapse. And so I cannot, in good faith as a provider, cannot support that recommendation based on what's best for her recovery.
And is she simultaneous to these screens from CPS when she's screening for your office? She's negative?
So because this is one of the struggles with clinical care, she wants us to do a blood test like every time they do a blood test. Now, it's not really clinically indicated, so it would be a struggle to really justify that that's needed. We did do it once, and our blood test was negative.
I will say that we have also had the issue with just with labs. Sometimes there are errors. The fact that it's consistent, I guess that's concerning. We have utilized in Marshall Health, Cabell Health System. We utilize the blood tests more just to have a witnessed screen where we see it coming out of the person, because the threshold for blood tests are such that often you don't detect things that are actually present. So we don't prefer them for that reason. But that's interesting that they're simultaneous to your tests, and yet they're still coming up with that.
Well, the only one of the blood, just because we couldn't get blood like every time, but yeah.
So we have a minute left. So I don't want to, Dr. Hanson, please ask your question to Laura, but I'm going to put an evaluation in the chat for the session. You also get it in the recap email. So I just wanted to get that in before we run out of time and be mindful of everybody's time. Like I said, there'll be a recap email with the slides and the recording and all that fun stuff. If you have any questions, please do not hesitate to reach out. Dr. Hanson, I'm sorry, go for your question or comment.
Oh, no, sort of, my comment is, I joke and say sometimes I feel like I have a degree in toxicology because of all the issues and the struggles that go along with utilizing it in my clinical practice. So I guess make a couple comments, try not to be super long. One of which I would find out if the blood is an EIA screen versus mass spec confirmed, because if your urine is confirmed with mass spec, that is more solid evidence of sobriety than an abnormal screen. The screen really should always be confirmed. And it's different technology, and their ability to pick up things is different. The second comment I'll make, and this is just I'll make this comment, and I don't mean for it to cause problems, but I truly believe that there are enough. Our drug testing at this point is so good that I do believe in some instances we are coming across trace amounts from the environment that's being picked up, and we are finding them in samples. An example, I had a patient who worked at a gambling parlor and was handling money all the time, and was testing for low levels of methamphetamine. And we discussed it and started to wear gloves when handling money, and the screens magically got better.
Yeah.
Which is just scary. Makes you just want to use a credit card now.
Yeah, no, she handles money with her job, and we've discussed that. So I can make that recommendation again to her about wearing gloves.
Yeah, but and the example I often give is, you hear these horror stories of people come in contact with trace amounts on counters and police raids and stuff like that, and people overdosing. So the stuff that's out there is so strong that even a small crystal or a little bit of powder can cause if it can cause an overdose, it can cause you to be positive on a drug screen, unfortunately. So, and I'm not trying to create excuses for all the people in treatment out there that are, looking for an explanation for their abnormal drug screen, but it further complicates drug testing, and it's hard, very hard. That's all I got.
Thank you, Dr. Hanson. That was great. We're a couple of minutes after. I really appreciate everybody staying on. The session will be a little bit easier to get through everything because you won't have me talking about echo, so it'll go a lot better. But our next session will be on February 14th. Again, you'll get some reminder emails about how to join the session and everything. In the meantime, please email the echo team if you have any questions. And we will see you next time. We really appreciate you coming on and taking the time.
Thank you, everyone.